We have we will continue our discussion with reference to the preoperative evaluation. Uh, we have covered a number of points related to it. Today, we will just try to have a look how we can evaluate the respiratory system or pulmonary system, and like how that will change our anesthesia management. Okay, so we actually stopped yesterday. We discussed about cardiac evaluation with reference to ECG and echo and thallium scan and cardiac CT and angiography, and just we had correlation. So we had stopped here at chest X-ray. Okay, so usually like a number of investigations which are there, because if you remember, I just mentioned that there is something relationship between heart and lung. Okay, because they are working in coordination, and usually even the symptoms or signs a number of times are correlated with each other. And similarly, like for example, just if we just think about chest X-ray, so with chest X-ray, a number of findings will be correlating with the heart function as well as lung function. Okay, so I will just usually there will be actually I will just show you that if you open this link, and then you will go to the books, and in the books you will go into OSCE books, so you will find some helping material with reference to radiology. Okay, so I will just take one of them as a reference. It seemed to be quite adjusted. Let me see. Mm, mm. Usually, as we know that we can get a lot of information, and just a second. So let me just explain, then we will just have look. Usually, either there will be some parenchymal, lung parenchymal changes you can find, some bony abnormalities, okay, and then heart shadow, okay. Usually, in the form of you will find some, for example, if you have some problem in the costophrenic and cardiophrenic angles, like in the maybe pleural fusion, okay. Uh, there is haziness. It may be either because of cardiac dysfunction, okay, or there may be development of pneumonia, okay. Then if you have any with reference to any bony problems with reference to pulmonary or cardiac evaluation, bony prominences will not be that much important, but still you can have like a pneumothorax because of some fracture, or like any trauma related. But usually you will be focusing with reference to if the heart is not functioning properly, there will be back pressure, so there will be increase in bronchopulmonary shadow and bronchovascular shadow. And then if there is any infective element, there may be like air bronchogram, and like in the form of pneumonia or opacities, or if it is a clear opacity in the form of maybe pleural fluid, as I mentioned. Okay, so usually you will be focusing on these things. Just a second. Then uh, just give me so in addition, you again, as I told you, that you have to correlate some other findings. Like if there is some tuberculosis, there will be some fever or weight loss, or cough with sputum. So you will just correlate. as they have mentioned here, tumors. Okay. Mm, pneumonia, abscesses. But I have these are the basic stuff. Check the name, date, check the quality, scan the film, list the abnormalities, and as they have mentioned, for diagnosis, follow up, response to treatment, trauma, tumor staging. This is journal. So radiological language, opaque, you know about it. If there is not clear shadow, that will be opaque. Radiolucent, if it is black, okay. Soft, hard, miliary, nodular, reticular. This is okay. Mm, Normal PA view. Actually, I'm not getting the information which I wanted. This is X-ray of massive pleural effusion. You see, the one side is totally white. Actually, usually when whatever reason is, when you interpret, for example, if you have some uh, haziness, okay, and you have some clinical symptoms, now you have to correlate with some other investigation, like you will do pulmonary function tests, okay, because usually with reference to pulmonary system, we have to rule out any mechanical problem, any problem with reference to gas exchange, okay, and the like cardiopulmonary reserve. So if you see that there is any opacity or anything, you will be looking at um, uh, gas exchange. So gas exchange, how will you see that? With the reference of ABGs. So you will be having a look on PaO2, okay, PaCO2, bicarb, pH. So that will be usually, these will be a more important thing with reference to like whether the gas exchange is occurring or not, okay. And some fine investigation may not done in every patient, will be like lung diffusion capacity, but usually you will correlate clinically, as well as you will find some radiological finding, and then you will do further, or with reference to mechanical, that will be that these in which you are looking at the spirometry, okay. Spirometry as a lab test, or peak expiratory flow rate. So that will be telling you about lung volumes and capacity, okay. So vital capacity and FRC, okay, and like the normal volume, tidal volume, inspiratory reserve volume, expiratory reserve volume. So you will have an idea what sort of pathology patient has. So X-ray, you will find something, then you will correlate clinically, ABGs, and then you will correlate with mechanical functions, and the cardiopulmonary, you can say the reserve will tell you overall how is the relationship between the heart and the lungs. If you, for example, I'm now the clinical end, like if you have a surgery in which there is diminished pulmonary functions, you will expect either post-op ventilation, okay, or post-operative respiratory problems. There will be chances, if not clear cut post operative ventilation, but still maybe you have hypoxia, okay, hypercarbia. Patient, if it is dependent, patient has some problem in which, for example, you give patient was on hypoxic drive. Now you give too much oxygen, so patient will not breathe. if there will be a bad outcome in the postoperative period. Similarly, the patient was hypercarbic and the hypercarbia was giving a drive for respiration. So now you wash out. So this can create problem. Okay, the patient had some emphysematous bully, emphysema. Okay, and now you gave more pulmonary like this one airway pressure, and you ended up having pneumothorax. So like you will correlate that. First of all, that's why in a number of pulmonary problems you always have a baseline, for example ABGs or baseline pulmonary functions, and then you will try not to disturb. Like for example, if the patient CO2 level was high, you will not wash out CO2 too much. Okay, similarly if the patient was already having some sort of hypoxemia, and that was the base of his ventilatory drive. If you give too much oxygen, that will create a problem. Similarly, as I told you and mentioned you about emphysematous, if you see the COPDR patient and you see now you are give you have to it is better to have pressure control ventilation. Okay, so that's how you will correlate. You will correlate the clinical findings with the practical as conduct of the anesthesia. You may avoid opiates. Okay, you may avoid volume control ventilation because extra volume can create problem. You will be looking more on the pressure control. You have to limit the excessive airway pressures. Okay, so that's how you will correlate. What else? Anyone wants to add something? ABGs, chest X-ray. Of course, in advanced, for example, if there is any pulmonary pathology in which you need to have further uh, investigation. What about bronchoscopy? Will bronchoscopy help initially? Like you, for example, if patient has some infection, okay, and maybe it was and like because of excessive secretions or excessive, maybe preoperative bronchoscopy can help you. Like if you are maybe pulmonary function will improve. Okay, so bronchoscopy is a thing which can help you in certain, of course, not in every patient, but in certain scenarios, it can help you. Similarly, if you find some atelectasis, if you find something like there is like you have a COPD patient, so there are a number of things which you can do. Of course, you have some clinical clinical parameters, like there is bronchospasm, patient is not breathing very nicely. So a number of things you can do to improve the post-operative outcome. Now, one of them, for example, is incentive spirometry. Okay, incentive spirometry, not only pre-operatively but also post-operatively. Then other thing, maybe an antibiotic course to treat the infection. Then maybe steroid course. Okay, then for example, if there is pleural effusion and you have a surgery, maybe if you have this pleural tap, okay, either surgically placed like chest tube or maybe pec tube or drainage, so it can help. Similarly, maybe you need because now I am coming towards a component with reference to heart function. Okay, so if for example heart is not functioning nicely, so maybe diuretics, okay, vasodilators, inotropes, like you have some congested finding. So maybe these things can help and the improvement of the post-operative outcome, because usually you will order some investigation. Now you have investigation in front of you, but you don't know how to interpret it. Okay, so whatever finding you had with the ECG, echo, chest X-ray, you should be knowing what interpretation would you like to do. Even pulmonary, this spirometry, for example, ABGs. Now you have to, because these investigations will be in your hand, and now you have to, the surgeon will be asking, what do you want to do? So now, if, for example, the patient condition is like lungs condition is not good, but still you have a surgery which you have to perform. You cannot change the lungs, you cannot change the heart. So you have to just get an optimization. So that's what you might need to do. Like maybe you can say that in addition to standard 1 monitoring and standard 2 monitoring, you might have, like for example, you might need to have arterial A line, okay, CVP, CVP, okay, ABGs. What else? You can special care about pulmonary pressures, okay. So these are the things which you can uh, do in such cases. In addition to the optimization which you can have, then you should have judicious fluid, okay, fluid management. Again, judicious fluid management. Of course, people will say CVP, but other thing you have to special monitoring in especially in this scenario will be urine output, and now in uh, 2023, there is the use of IVC compressibility. Okay, so like you can have evidence of IVC compressibility, and you can give fluid accordingly. Like if there is hypotension, or if there is you can just see that how much fluid your patient can receive. Well, CVP, or if, for example, pulmonary artery catheter, of course, usually now pulmonary artery catheter has already become not they are it's not being used as maybe 20 years ago it used to. Okay, then cardiac output monitors. So in this scenario, if you have any like expected, because you will find patients with COPD, restrictive lung disease. This will be, for example, if you have a patient with rheumatoid arthritis, okay, or any occupational lung disease, okay, or for example, you have a patient. I missed actually smoking. So smoker, you have to you see that there is some like element of reversibility. Maybe you can have, according to the time you have, smoking cessation will help you out. Okay, so this will be part of your preoperative pulmonary optimization, that you will quit smoking accordingly, and you will get the results with reference to the time duration. You will get the results in the form of reduction in nicotine level, carboxy hemoglobin level, and carbon monoxide level, and gradually sputum clearance according to the duration you have. So this thing you can do. Again, there are certain medications. Would you like, for example, if you have a patient with diminished cardiac reserve, with in the induction, you will try to have etomidate. Okay, this is one thing. Then now it is not available, but you usually thiopentone. If you have a patient with any adverse pulmonary outcome like airway reflexes, so thiopentone, because does not blunt the airway reflexes as blunted by propofol. So in that cases, thiopentone was just to be avoided. So propofol will be a better choice. Similarly, with reference to muscle relaxant, maybe atracurium, and cisatracurium does not have histamine release. So maybe V-coronium or rocuronium you can use. So like because usually whatever investigation we have to interpret clinically. So like that's what I wanted you to know, that whatever investigations you do, you should be knowing how to interpret it. There are some other investigation which are not apparently looking as pulmonary, but albumin level, okay, because albumin level is the one which is related, which is responsible for the oncotic pressure, okay. So if for any whatsoever good reason, if there is low albumin, so there will be more chances of pulmonary edema. Okay. So you have to be careful, and maybe you can give some albumin just to increase. Not only it will reduce the volume of crystalloids you give, it will increase the oncotic pressure, which will be helping you in avoiding avoidance of any adverse pulmonary outcome. Okay. So just any comments from any of the participant, please? Anyone wants to add something? Yes, please. No comments. Nothing. Just a second, please. Let me see if anything I can add. Pulmonary, cardiopulmonary exercise testing. I had told you yesterday that how you can use it. Actually, there was an article which I am trying to find with reference to preoperative risk stratification. Just a second, please. So, risk stratification. As I told you, from where we started our discussion, there are some surgical risks, there are some uh, cardiac risk, respiratory risk. So I was just trying to have a look here on the respiratory risk stratification. Just a sec. Yes, okay. This is for kidney, this is for liver. They have not mentioned much of pulmonary risk factors here. Yes, you see, type of surgery, okay. And like there will be more chances in a high risk surgeries, upper abdominal and thoracic surgeries. Okay. Then with reference to age, okay, and previous history of COPD, high obesity, prior stroke. If you are giving too much blood transfusion, that will be also a pulmonary risk factor. You see, chronic use of steroid, maybe you need to have replacement of steroid, not only, and also, as I mentioned about smoking, alcohol also has some relationship. As I mentioned to you, albumin. Okay, so these were the things. Okay, anyone, any more comments? Anything you want to add on, please? Asthma, again, asthma, you can have some reversibility with the bronchodilators. You can have, yes, in addition to all this, which I told you, with reference to like diuretics and antibiotics, you can have some use of bronchodilators. I did not mention COPDs. You see, FEV1 of FVC ratio will tell you a lot of information because in obstructive lung disease, there is more reduction in FEV1 as compared to FVC. Okay, so the ratio is decreased. However, in restrictive lung disease, both of them are reduced, and actually FVC is reduced more than FEV1, so the ratio is more than one. Okay, so these are the things. Then again, some other conditions like GB syndrome or any failure, you will have something. I think I have just highlighted the main points which I wanted to have. Cardiopulmonary exercise testing, it's in detail, but usually you have an anaerobic threshold, okay, in which after that there will be more CO2 production than oxygen being utilized. So that is considered as anaerobic threshold. And then also they measure the maximum VO2, maximum oxygen utilization, that occurs in the form of METs. So it is exactly, I have now not seen it actually, but it's more on the theoretical component rather than practically. I have not seen actually anyone doing it, but it's written in like recent articles and books about cardiopulmonary exercise testing. With reference to thoracic anesthesia, we have the same three leg tool as I told you: mechanics, parenchymal problem, and cardiopulmonary reserve. So it's the same thing which we said three leg tool. So they are doing the mechanics, parenchymal function, okay, and cardiopulmonary reserve. So actually, this is not only for thoracic surgery. You can use the same mechanics, same theory in any other surgery. Okay, because that's how. Of course, there will be something with reference to the resection. That is resectability. Okay, so that is something extra with reference to thoracic surgery. But generally, even if you don't, if you are not doing a thoracic surgery, this information can help you in any patient. So, and other specific things you can have, as I mentioned, CT scan or MRI or things like that. And there may be in any respiratory problems, or if you have a mediastinal mass that will be involving the airway, so that will be extra. But usually these are the things. And one thing I missed is flow volume loops. Okay, so flow volume loops will also help you in assessing some of the aspects with reference to respiratory system. So I will just stop here. Today, actually, I had to go somewhere, so I just tried not to miss. Tomorrow, actually, I'm on call. I will try if I will be able to make a class. Otherwise, we will continue our routine on Monday. So there will be. I will just try to have a recap on all the things, and maybe some other points which I have missed. So if one some you have not seen the previous discussion, I will suggest you to go to this channel, okay, and you will find uh, some of the discussions, this preoperative assessment, then some investigations, and then coagulation review, and we had cardiac review. And in the playlist, because before I had done a number of time about this preoperative risk stratification and anesthesia planning, so there was some of the discussion you can find here. Yes, this one. And in which I had done in detail. This is actually not only preoperative, perioperative management, but some important points which may be missed. I have done in detail here: is respiratory disease, liver disease, renal disease, pregnant patient, pediatric patient. Because remember one thing, anesthesia is all planning. If you are able to have a nice plan, okay, then rest of the things will become very easy. So planning, the same thing which I have discussed here: optimization before surgery, optimization and anticipation before surgery. So anesthesia planning is the one which is more important. Okay. So thanks a lot. You cannot hear? All of you cannot hear me? Or only this doctor is not able to hear me? Am I audible to you?
Yes, yes, we are hearing you.
Okay. So thanks a lot, Dr. Asmat. I think there is some problem. Yes, yes, I can. Dr. Asmat, you have not joined audio. Unfortunately, she has not joined the audio. So thanks a lot, all of you, for your presence. You all are welcome to have any question anytime. Thank you very much. If anything I have missed, please pardon me for that. Uh, I have tried to give you a concept, because usually we see the investigation, we evaluate the patient, but we don't know what we have to do. So that's the more important thing, that whatever you are doing, whatever question you are asking, you should be knowing what will be the clinical implication for that thing. Okay. So bye bye. Inshallah. Tomorrow I will try to have, if I am not able to make it, day after tomorrow, inshallah. Okay. Bye bye. Assalamu alaikum.